Hello guys, welcome to my channel. In this video I will be talking about hypermetropia. So starting it with its definition, it is a type of refractive error in which the parallel rays of light coming from the infinity are focused behind the retina when the accommodation is at rest, right? When the rays of light are coming from the infinity and they are focused beyond the retina, so at that time the image formed is not clear, it's going to be blurry. Now talking about its classification, it can be classified on the basis of its etiology or by clinically. On the basis of etiology, it can be classified into axial hypermetropia, curvitural hypermetropia, index, positional, and because of absence of crystalline lens. Talking about them one by one, axial myopia is when the axial length of the eyeball is shorter, right? When the axial length of the eyeball is shorter, then there is going to be hypermetropia. The rays of light are going to be focused beyond the retina. For every 1 millimeter decrease in the axial length of the eyeball, there is +3 diopter of error, right? And now talking about the curvitural hypermetropia, it is because of the increase in the curvature of the cornea or the lens. It's basically the flattening of the cornea or flattening of the crystalline lens, so that image is going to be formed beyond the retina. Now talking about the index hypermetropia, it is when the refractive index of the lens is decreased. Is the part of aging. So when the refractive index of the lens is less, its converging power is less, right? So it cannot converge it in the right point, so it goes beyond it. Now talking about the positional hypermetropia, it is about the position of the crystalline lens. When the lens is placed posteriorly, right? When the lens is placed posteriorly, then in that condition also there is going to be hypermetropia. Now when there is absence of crystalline lens, then also it can occur, because the one of the converging apparatus in our eyeball, that is lens, which accounts for about 15 diopters, right? That is lost. So of course in that condition also hypermetropia is resulted. Now talking about the clinical classification, it can be classified into simple or physiological, non-physiological and functional, right? So talking about them one by one, what happens in the simple or physiological hypermetropia is that, by the way, it is the commonest form, right? And it results from the normal biological variation in the development of the eyeball. And the non-physiological hypermetropia is due to the conditions which are outside the normal biological variation of the development. Congenital non-physiological hypermetropia is seen in microphthalmos, when the eyeball is smaller than the normal, nanophthalmos, microcornea, right? And acquired non-physiological hypermetropia occurs in the conditions like senile hypermetropia, right? And positional hypermetropia due to posterior subluxation of lens, aphakia, because of absence of lens, congenital or acquired. Functional hypermetropia, which results from the paralysis of the third cranial nerve, which is required for the ciliary muscle function, right? So the paralysis of that nerve causes loss of accommodation, then of course the near vision is going to be affected. And also in the case of internal ophthalmoplegia, there is also going to be functional hypermetropia. Now talking about components of hypermetropia, There is total hypermetropia, latent hypermetropia and manifest hypermetropia. Total hypermetropia is the total amount of refractive error which is attained after complete cycloplegia with atropine, right. It is the sum of latent as well as manifest hypermetropia. Latent hypermetropia, this usually remains latent, right. It is the amount of hypermetropia which is usually about 1 diopter, which is normally corrected by the tone of the ciliary muscles, right. So it may go unnoticed. Latent hypermetropia is disclosed after using atropine for abolishing the tone of the ciliary muscle, right. Now talking about the manifest hypermetropia, it is the remaining portion of total hypermetropia when latent hypermetropia is excluded, right, which is not corrected by the ciliary muscle tone. Total hypermetropia equals to latent plus manifest hypermetropia. Now talking about the grading of hypermetropia, according to American Optometric Association, there are 3 types. They are low hypermetropia, moderate and high. Low is when the refractive error is less than or equal to +2 diopters. Moderate when it is between +2 diopters and +5 diopters. High hypermetropia when it is greater than or equal to +5 diopters, right. Now coming to the symptoms of hypermetropia, it may be asymptomatic as well, as I already told you that because of the ciliary muscle tone there can be some amount of latent hypermetropia, right, which can be corrected by accommodative effort, so that may not produce any symptoms. Now the second one is asthenopic symptoms. Asthenopic symptoms means the symptoms which are because of sustained accommodative efforts when there occurs tiredness of the eyes, headache, watering from eyes or mild photophobia. These are the asthenopic symptoms, and it occurs because of sustained accommodative effort to have a clear vision, right. Now the third symptom is defective vision with asthenopic symptoms. When the amount of hypermetropia is such that it is not fully corrected by that effort, then the patient complains of defective vision as well as asthenopic symptoms because of accommodative efforts. Now the fourth symptom is defective vision only. It is when the amount of hypermetropia is very high that the accommodation is not going to correct it, then the patient usually does not accommodate. Then there occurs marked defective vision and no asthenopic symptoms. Now talking about its signs, the size of eyeball is small. The axial length of the eyeball is small, so size of eyeball is small. Cornea is slightly smaller. There is shallow anterior chamber. Anterior chamber is between the cornea and the iris. During retinoscopy or autorefractometry, hypermetropic error is seen. During fundus examination, small optic disc is seen and a characteristic feature called pseudobabyllitis is seen, which means there is no swelling in the disc, but it may look more vascular, which mimics it, so it is known as pseudobabyllitis. And because the retina as a whole may shine a lot, so that causes short silk appearance. Now talking about its complications. Complications include recurrent styes, blepharitis and chalagia. These are probably due to infection introduced by the repeated rubbing of the eyes, which is done to get relief from the fatigue and tiredness due to asthenopic symptoms, right. Now accommodative convergent squint. This may develop in children due to excessive use of accommodation. Third is amblyopia. It may develop in some cases. And finally primary narrow angle glaucoma. Now how do you treat it? There is optical treatment and surgical treatment. Optical treatment is by the prescription of convex lens of appropriate power, which can be given as a spectacles or contact lenses. Now surgical treatment is by the surgeries, right? So what surgeries are there? There are cornea based surgery and lens based surgeries. Cornea based surgeries include TLK, thermal laser keratoplasty, hyperopic PRK. PRK meaning photorefractive keratectomy, right? And hyperopic LASIK, LASIK meaning laser in situ keratomileusis, and CK, which means conductive keratoplasty. And some lens based methods are PRL, phakic refractive lens, or ICL, implantable contact lens, and RLE, refractive lens exchange. So these are the treatment options. So that is all about hypermetropia, guys. Thank you so much for watching this video. Don't forget to like this video. Thank you so much.